All right. Welcome, everyone. It's so great to see the faces in the room and also the folks that are on Zoom. This is a really exciting time for me. There were Rollins Grand Rounds prior to the pandemic, and then we haven't done it for a while. And one of the things that I heard since I started here was how much people missed the opportunity to bring all departments together to hear about work that's relevant across the whole school. And so this year we put together a set of folks once a month from now until I think May that really represents the depth and breadth of things that we do at Rollins. And so I'm thrilled to kick this off with Dr. Susan Sherman, who is a Bloomberg American Professor of Health at Johns Hopkins Bloomberg School of Public Health. Susan has had a really long career in harm reduction research and advocacy and practice. She really has dedicated her work to improving the lives and health of people who use drugs, particularly sex workers, but many marginalized populations, through a variety of different kinds of interventions. And I think, much like many of you in this room and online through the Rollins School, has really always driven her research with an eye to how will it be used, how do we bring that evidence base to practice, and how do we advocate to make sure that happens. So without further ado, welcome Dr. Sherman.
I really have to have my glasses, sadly. Okay. Thanks. It's nice to be in this swanky building, I have to say. Hopkins people have a little bit of envy of these beautiful, although they visited, apparently, the powers that be, and we're going to have buildings like you in 3 years. At least one new building that I'll get to be in. Thanks so much for having me, Danny. I really appreciate being here. I was here a few months ago in the summer just to check out Danny's new digs, and it's really nice to be here and see all of you online. And Hannah Cooper, if you're there, thank you for your email. So I'm going to talk today. It took me so long to get this title, I have to tell you, because how do you talk about the overdose epidemic? It has so many paths and roads and stops and starts and fires and potholes. So hopefully I encapsulated it in.
Can you move the cursor so that them?
Nothing's happening. I'm moving all sorts of things. That. It doesn't work here. Yeah. Oh, there it works. Okay, cool. In these 4 questions, I thought it helps me keep my boundaries and guardrails, and hopefully you'll learn something new, and this gives you foods for thoughts. So I started working with people who use drugs. I lived in San Francisco, worked in the AIDS epidemic with men in the early 90s, gay men, and then went to North Carolina for a master's and really wanted to get back to women's health, which I had done in college. I'm not going to go down all about me. And women and HIV was all about drugs. It was all about gender relationships. It was a lot about violence. It was a lot about systemic trauma in their lives. And so it took me into this long career with harm reduction. I never thought that there'd be another boom with the opioid epidemic. I thought I started to focus on other things, and here it came. And in Baltimore, where I'm from, where I live, of course, there's always been an opioid epidemic. So today I'm going to talk about what's the magnitude of the epidemic now, how has it shifted over time, what are some of the drivers, and what are policy and practice solutions. I'm going to weave a bit of my work later in the talk. So what's the magnitude of the current epidemic? You know, these numbers are so astounding, and every time I write a paper or a grant, I have to go back and see what are the most updated CDC numbers. Have they done it for the last quartile? What's in Maryland? The data are lagged in Maryland. Maybe they're more up to date in Baltimore. The numbers just grow so over time. And even though you can always give X% higher, which I'm going to do later, I just think if we sit with 110,747 predicted deaths, that is astounding. And if it were hitting maybe different members of the population, or it was somehow more visible, there would be overdose prevention sites and syringe service programs at every corner, low barrier drug treatment. I mean, it's an astounding number of people. And there was a decrease before COVID, but for lots of reasons, it started ticking back up and has continued during COVID, including now, of course, the tainted drug supply. Leading cause of injury of death in the U.S. more than guns and motor vehicles combined. And even though you may know this, these are astounding facts, and you can read them. So, and the most astounding fact to me is that overdose is a significant contributor to the fact that we are losing years and days in life expectancy. That's pretty tremendous with something that could be preventable. Okay, so a little bit here, I do give some numbers, a little bit about synthetic opioids, because you can't really talk about the opioid epidemic like some people have said in Baltimore. It's not your grandfather's epidemic, which was all heroin. Synthetic opioids, which came into the U.S. For really market reasons I'll talk about a little bit later, have totally permeated and taken over a lot of the market, and you're going to see some trends over time. Here's data from Baltimore, where I live, and Fulton County, where you live. Higher numbers of overdose deaths in Baltimore, 171.2 fatal overdose deaths per 100,000 residents. And 32.8 in Atlanta. Obviously, that's far too many. Baltimore City, I'm going to show you the slide, has the highest death rate in the country by far. Almost 19 times and double the rate of car fatalities, respectively, and quadruple the rate of firearm deaths in Baltimore, double here. I don't know how much firearm gun violence permeates your local news. In Baltimore, it's just astounding how much it permeates the news. And to think that 4 times the amount of people are dying, often alone or in alleys or with friends because of an overdose, is astounding. All right. So in terms of, even though I'm saying what's the state now, changes over time, you can see the states that are the darkest that have had significant increases from 2019 to 2020. Over 40% are the darkest color. The lightest color is up to 20%. The next lightest color is 21 to 40, and then more than 40%. And you can see the states. I was thinking about why those states, Montana, Idaho, Wyoming, South Dakota, thinking about the roads there and truck stops and patterns, why it's so different there than if you look in, east to south, that kind of curve with Kentucky, my home state, in the center. Highway routes definitely had something to do with the spread of this current opioid epidemic. Places like Kentucky and New Hampshire and Ohio and West Virginia, where you didn't have such opioid problems before, addiction. Of course, it's a story of prescription medicine and then controls to stop the pills flowing. And then heroin started coming into these places where it had never been before. And it's just really startling to me that how in the West, the Northwest, that is different. Oregon has a lot of overdose rates and lots of synthetic opioids, but it hasn't permeated to the states to the east, for example. So this is what I was talking about. This is an amazing article that you could look up. It came out, the San Francisco Chronicle did work. This is kind of New York Times style. You can put in your county, your city, and then you see the overdose rates relative to other cities, and it shows this is overdose deaths in areas over 500,000 from 22 to 23, and you can see Baltimore, it's just kind of crazy. It's such an outlier, followed by a county in Tennessee, which is, horrible for Tennessee, but unbelievable, followed by Philadelphia, which has had a penetration of xylazine, which is an animal tranquilizer, also in Baltimore. Horrible for your skin and wounds, really creates wounds all throughout your body, not just the point of contact. That's something that's happening on the east, and as everything will slowly work its way around the country. And then these are those states that were highlighted that had over 40% increases in overdose during that period of time. Okay. It's always funny to pick what slides do you pick that aren't mine, because there are all these great national data to set the stage, that aren't going to overwhelm people. So if you're visual with lines or you're visual with maps, I have something for you, because these numbers are there are lots of ways to show these data. So how has the epidemic shifted over time? There's some really well-written articles, one in particular by Nab Dasgupta. Some of you might know Nab in the American Journal of Public Health with his colleagues Leo Beletsky and Dan Ciccarone, and they talked about the structural determinants of different waves of the opioid epidemic. So the first wave was this rise in prescription pill overdose death. People had pills in Baltimore City. Still, there are 32 pills for every adult 18 and over. It's astounding the number of pills that were prescribed in the U.S. New markets, marketing to physicians. It's a pretty unbelievable tale of how that happened. Then, of course, the government and medical societies and powers that be states responded, employing the PDMP, which most states had, prescription drug monitoring programs, to see where people were getting. Pharmacies were people that were basically pill mills, doctors who were handing out pills, people that were hospital shopping. It all became central information that was readily available and really stopped the number of pills that were coming, illicit pills that were being prescribed. So, of course, you've created this pool of people who are addicted, and it's not like just because they can't go to this doctor or this doctor for pills anymore, they're going to stop needing drugs. A lot of people had very real chronic pain, basketball star in West Virginia, or the 15-year-old in Texas, or people in Baltimore City who've lived with a lot of pain in other urban areas and no jobs and all the kind of a lot of despair for a very long time. So that gets constricted, and Mexico, I am totally simplifying this. Mexico and Colombia have a war. Heroin starts over drug routes in the U.S. Heroin becomes very cheap. When I started doing work in Baltimore in the mid-90s, a pill of heroin was $20. It's now like $4. And that is like so regressive if you think about inflation. But heroin started to become very cheap and was easily available. Pills, fake pills were being sold on the street. So then there's interdiction with the DEA with that, of course, because heroin was flooding in from ports and planes and mules, et cetera. And so what does a market do? It adjusts. Fentanyl is 50 to 100 times more powerful, and its analogs powerful than heroin, which means if you have a block this big, you can bring it in the country more easily than you can bring, metaphorically, a block 10 blocks. So that's what happened. And as you know, I don't know, did anyone just hear that the biggest number of secretaries from the U.S. just went to Mexico to talk about the border and talk about fentanyl coming in through the border, which is kind of unheard of. The problem continues. It's escalated. And, there's so many complicated reasons. It's not Mexico's fault or China's fault. I mean, how is it that so many of us are in pain? And we're, so many people are multiply diagnosed with mental health, have mental health diagnoses, or, opiates, like the opioid of the masses has been true for a very long time. So I'm not putting the blame on any one actor, except there really is a lot of despair, and this is what's readily available. You can drive through neighborhoods in Baltimore, and you see as many guys on the corner selling drugs as you see corner stores, and no evidence of a lot of neighborhoods. There are other businesses. The vacancy rate in Baltimore is 23%, et cetera. So, rise in synthetics. Now people say that, and that was around 2016, and then you saw those percentages. You all right now 67% a few years ago, us 87% of the illicit supply being fentanyl of drugs that are tested. People say there's a fourth wave, which is polysubstance use, because more fentanyl is being coming up with cocaine, whether people use it together or it's produced together and they don't know that they're using an opioid. Where I live, there's always been a mix. It never was kind of one substance. I think this narrative around polysubstance is really interesting because there have always been a lot of substances that are used. People, when in Baltimore, for example, there's something called a speedball, which is a mix of crack and heroin because it helps you kind of get off your roll when you're nodding, et cetera, with heroin, to have crack cocaine, which is a stimulant. So people have always been mixing drugs. It's just a pet peeve of mine that's the new phase. The new phase is that no one knows what they're getting. Drugs are criminalized. They were decriminalized for 2 years in Baltimore City, which we analyzed that data to see the impact on crime, just to say no increased crime. It was during COVID, but no increased crime. Portland now, Oregon is experimenting with decriminalization, the whole state, and that's a whole nother story. But when you don't know what you're taking, it's an unregulated market. You may be allergic to shrimp and you have no idea that shrimp is in a hamburger one day, not the other. I mean, it's just really, and that's why, and I'm going to talk a little bit about some of the drug checking work that we do, but that's why people have started point of care drug checking or state surveillance of drugs. Okay, it's hard to just stay on the slide. That's why I needed 4 questions. All right, so this is just another graphic for people that see maps, and it's also astounding looking by county overdose deaths in the U.S. over 18 years, with obviously darker the color, the higher concentration of death. So at this point, you can see, I mean, the whole country except for the middle a bit and a bit on the west is kind of on fire. So if you noticed when the talk title talks about inequalities, when you think of this epidemic, what do people think about? If they have a picture in their mind, who do they see? Overdose epidemic, heroin epidemic. Who's in your mind? Okay. Yeah.
People imagine.
I know you're like, why is she asking questions?
I think it depends if we're talking about the opioid epidemic in general. I think a lot of people are still thinking about like people using Vicodin, like mostly white people in rural areas using Vicodin or other prescription opioids. I think people who are more aware of the heroin epidemic have a very different picture of like someone in an urban area using injection drugs.
Right. So those are really 2 different time periods, and we're going to talk about that, but thank you.
But I think they're still conflated in the like popular imagination. Right?
Well, and also, what's the meaning of the conflation? Does it matter? It does matter because there's more empathy towards one than the other. Laws have been different for one than the other. Although it's still, the laws are still not great. Okay, so we're going to talk about gender and we're going to talk about race, ethnicity, because there are differences. So if you can see over time, there's been a rise in females, but there's really been an exponential rise in deaths among males, which is interesting to me. Any study I've done or other cohorts in Baltimore, it is often 70% men, 30% women. Any study of opioid users, injectors. Now, obviously, I work with female identified sex workers, so those are all 100% female. But when we do mixed gender studies, it is mostly men. And when we're doing a new study I'm going to talk about right now, we have 35% women, which is kind of astounding. So men have always been more often get in studies. They're more out and about. A lot of women get their drugs and their syringes from men. There are different patterns of drug use, locations where people use drugs, but still, over time, great increase in male deaths, which the difference has always been the case. Again, it's the market, the drug supply. There's been a lot lately written, like in the past few years, about the fact that Black men actually have the highest death rate still. And even though people have this notion of like an old man in Baltimore City shooting up heroin, and that was a time of the past, it's not a time of the past at all. If you look at the differences in these rates, this is age-adjusted overdose rates over 5 years. This is from that great San Francisco Chronicle article. Pew Research actually produced this. A lot of CDC Wonder data informs other graphs and maps, et cetera, in this talk. And among women, and the other astonishing thing that a lot of people don't talk about, there actually are people doing work at Hopkins on Native American opioid use, is the fact that lighter line commingling among men and higher among women is among American Indians and Alaskan Natives. And if you think about disparity and you think about lack of jobs and you think about environmental decay, it makes sense. But it's not, in my harm reduction world, it only in the last few years has become more of a conversation. And obviously now that's just my perspective. Obviously, if you're living on reservations or you're doing work, but there's a lot more conversation about these high rates of Native American dying from opioid overdoses, and also the fact that such a high percentage of women. So to this narrative around whites and when the current epidemic started happening 2010-11, and you had all these stories of, horrible stories of kids that died and moms, exposés of moms and dads who lost their children, the football star who got a leg injury and then all of a sudden was addicted to pills, then started using heroin and went to treatment, came out and overdosed. It wasn't that, it really became that there was a different ethos around compassion. If you think about the crack epidemic, and what do people know what sentencing was between crack cocaine and heroin? Do people know the difference in the 80s? 50 times harsher sentence if you were caught with the same amount of crack versus cocaine. Crack is cocaine. Obama changed that, took that long. Many years later, many people arrested, many completely racist articles about Danny came back sick from India, crack hose, which is an unbelievable, not COVID, unbelievable term, but totally different narrative. Now, like I said, for the sake of what I'm talking about, I'm saying this very much there's a lot more to say about all of these slides, but it is true that there was a different narrative. And so people wrote really interesting commentary. And meanwhile, there were higher overdose deaths among African Americans and other ethnic minorities, but this compassion towards white, and people did some interesting media analyses, and the different take on versus HIV among people who inject drugs versus what was happening with pills to heroin, et cetera, was really different. So there's a lot of interesting writing about that. These are some of the articles, but I think it's really important to always think about the nuances in this epidemic and why sometimes, and how it's treated, because it's a horrible example of racism. Although, even though people had it was a white epidemic, it's not like decriminalization happened or evidence-based drug treatment was scaled up. There were all these treatment programs that weren't certified, that weren't practicing. They were doing withdrawal, zero tolerance for people. People were leaving and overdosing. It's, jail and drug treatment, abstinence-based drug treatment are two of the highest risk factors for overdose. Okay. So drug overdose rates among Black men in the U.S. more than tripled in these 5 years. 5 years that you were not seeing that in the media. People were not talking about it. Since then, there's been a lot of writing, but still, it's so hard to backtrack. It's like anything. I mean, it's like an infectious disease, although obviously this is not an infectious disease, but it's networks of people who use. It's so once you have 10% more, 20% more, it's very hard to get the rates back down, particularly when you have a completely adulterated drug supply and people don't know what's in it. So there also have been stories of people saying that was the weirdest high, it lasted so long, and it was heroin, not fentanyl. A lot of people, most people now in many cities, in my city, haven't used heroin. They're addicted to fentanyl. But if you don't know the relative proportion, which some drug checking machines can tell, if all of a sudden it's 80% versus 20%, big numbers, your body is going to be overwhelmed by that amount of fentanyl, even if you've used it. Heroin market was just a different market. Baking soda was more of the cutting agent versus we went through a period in Baltimore with meat tenderizer being a cutting agent. It was right around the holidays 4 years ago. You can only imagine what meat, it tenderizes flesh. I mean, that was a horrible thing with wounds. There's not a lot of low barrier wound care available to people. That was really a foreshadowing for what's happening now. But the point is, we don't really know what's happening with the drug market. There are people that know. And there is increasingly conversations between public safety and public health, but not to scale. So now we're going to talk about a few drivers. This could be the whole talk, but we're just going to talk about a few key drivers that I've worked on and think are really important. Unsafe, so we're going to talk about the drivers, and then we're going to talk about some programs. Thinking about the unsafe drug supply, we're going to talk about point of care drug checking, structural inequities and accessibility to evidence-based harm reduction and drug treatment programs, which to me are one and the same. We're going to talk about overdose prevention sites and also a drop-in center that I started in Baltimore. So this just shows you the rates of fentanyl. The blue is fentanyl only. The orange is fentanyl and heroin. And then the gray is fentanyl cocaine that were reported nationally from national forensic labs in this 5-year period. So that's just an incredible increase in number without the methods of collecting these data changing much. I'll tell you, this is from the DEA. Labs are completely our friends in this. And if anyone does work in this field, we worked with the police lab in Baltimore 5 years ago when we did studies and basically tested technologies for drug checking. We actually helped to get drug checking decriminalized in Maryland. The police lab was so happy to work with us. They had all drugs seized in Baltimore cities, and they tested drugs, the drugs that were going to trial. So they don't test drugs that don't get, if somebody's arrested and then the charges are dropped or they make a deal. So they had all of these data that people in public health didn't have. We partnered with the chemistry lab at the School of Medicine. We also work with a national forensics lab in Maryland. So labs are really, who do drug testing for various reasons, have been really eager to work and get the information in public health settings. I'm sure for all the work that you do, you can think about who are people that have information. A lot of times people aren't partnered up, and it's just important to always be expansive in your thinking. And the chemists in the lab at Baltimore Police Department with whom I worked and I have feelings about, they're chemists. They're very different than the cops on the street, which doesn't matter. But the point is they were an untapped resource who was really happy to work with us. In Maryland, 2 years ago, there started to be a state pilot for organizations to send in samples, swabbing samples to be tested in one of these national labs that we also work with. And so the program is called RAD. State surveillance, like for HIV or for syphilis, is really important to know what's in drug samples. So this is just programs over time. I think in the end there were 13 or 16 programs. The green on top is a county called Cecil County. There was a gap in a month in May. This is from October 21 to August 23. That's Cecil County's, the percent of samples that contain xylazine over time. Cecil County is at the corner of Delaware, Maryland, and Pennsylvania. The highway goes through there, 95. It is astounding. They have just incredible rates of xylazine. There was a great harm reduction organization there, a nurse who, Jason Beinert, and I have no idea he wanted to come work with us in Hopkins, who did a lot of the testing and does a lot of education around xylazine, because now we have this yet another tranquilizer, like ketamine is a horse tranquilizer. A lot of people use recreationally, that deteriorates your skin and whatever the derma under your skin. You can see that I'm a social scientist. Not just at the point of, and so it used to be that people, if there were bacteria, that they would have problems where they injected drugs. This, no matter where you ingest, you get wounds, and terrible wounds. And a lot of syringe service programs and other harm reduction centers and drug treatment centers and emergency rooms aren't equipped to see people with wounds. So if you see if you can imagine the number of people who are using drugs in a lot of areas, Baltimore City, for example, and there aren't or Cecil County, which is rural, it's rural. If there aren't services, people are walking around, you just can only imagine what happens when you have really gaping and untreated wounds. And there's a lot of stigma around wounds. They're ugly, they smell, they get infected, etc. So it's really we're always chasing our tail with what to do next, what to work on next. And although some people have had low barrier wound clinics connected to their harm reduction, like integrated harm reduction programs, not to scale the problem right now. So now you're going to see all the great graphics from studies of ours. And thank God we have a doctoral student and a staff person who are graphic designers. So we don't have to go out anymore and spend a lot of money on graphic designs. We have really good in-house people. So the SCOPE study, Substance Checking Outreach and PrEP Engagement, is a NIDA-funded study where we are basically, I live my life, my research, a lot of it's in mobile vans, implementing and evaluating a mobile van drug checking program. So this is like a really retrofitted RV van that we bought. Let me tell you, the RVs really went up during the time of COVID because everybody, like, they doubled in price. So what was $40,000 in my budget all of a sudden is $80,000 because everybody bought RVs during COVID, not for these purposes. So basically, we bought a van that we're going to have Jason and another nurse doing wound care. And he's taught wound care and does wound care for a lot of organizations in Baltimore. I mean, as Danny said, the point of a lot of my research, I've done a lot of observational research, is always to make a point with what we do, whether it informs drug policy for the state or nationally, or a lot of the work we've done with sex workers, occasionally people use it to talk about decrim of sex work or to make police accountable for abusing sex workers. But that's not as hot as all the drug work, which is very interrelated, that I do, work around the opioid epidemic that luckily really informs policy. So we're starting this van, but before that, we've already started baseline data collection. We're going to interview 600 people. We're conducting baseline in an area, then we introduce the van, then we go to another area, different hotspots in Baltimore City. Outcomes are PrEP uptake and HIV risk behaviors, and we're also looking at cost effectiveness. And the van is called Check It. So a lot of the studies that I've done, including I'm going to describe a drop-in center, we don't just recruit from the people that go to the particular, we're not just recruiting people that go to this van. That's a van, not our van. Our van is prettier. The Check It van. We don't just recruit from there. We want to go to areas to see how these risk behaviors and overdose prevalence, et cetera, has changed their community level intervention. So we're hoping, and we also see how many people go to this harm reduction and other services. This is not the only game in town, but it is the only game with a $45,000 FTR drug checking machine that we've taken 2 years to calibrate to the drug market. I used to always say it's like Spotify. The more drugs you put in, the better the algorithm is, even though there's a huge drug dictionary. But this is not made to be on a mobile bumpy van. And I mean, I can't tell you, the reps, they have made so much money off public health, different cities like San Francisco, New York, Chicago, that have implemented drug checking, but they're very testy machines, and they've taken a long time for us to validate with our lab partners. So we send samples to our labs and we kind of compare what we tested. All right. Another driver is structural inequalities. I'm going to go through this quickly because my mouth is dry and I'm talking a lot and I want to hear what you have to say. So obviously it's crazy to even have these bounded, unstable housing and food, lack food scarcity and extreme hunger. Arrests and intense policing are the root causes of so many downward behaviors and outcomes in people's lives. And of course, people adapt in different ways to try to avoid or cope with all of these various traumas. So, and this is a lot of the observational work that I've done. So I'm going to quickly go through some of what we found. Unbelievable rates of unstable housing. In that first study, it was a paper by Jennifer Glick, who looked at correlates of women who identified as lesbian or bisexual, and there are much higher rates of being unhoused and higher rates of overdose, et cetera. But unstable, and then the next study was looking at women who use drugs, not just female sex workers, who, in a current study that we have, we're analyzing that was taking place during the time of COVID. And women, of the 27% of women who use drugs who reported unstable housing, 37% reported recent overdose. Housing was a predictor of that. These things are all interrelated. I'm not going to tell you every significant finding, although it was good to look back and see them all, because it reminds me of the people with whom we work and the really intense nature of the lives that people live. And why would they use drugs? How do people cope with trauma or not being in a house stably? We also, it took me so long to look at food insecurity. I couldn't believe it wasn't until 2017 that we put questions in about hunger, and we found that an inordinate 54% of women experience weekly hunger. And in the paper, Sana Lim's paper, we found that hunger was significantly associated with HIV prevalence. And I was really kind of ashamed of myself that we'd never asked that, because of course, when you see things and shine a light on things, that's when you can do interventions. Okay. Arrest and policing practices, just unbelievably prevalent. And you know, it has to do, a lot of our earlier work, people were arrested during the times when our former mayor and then governor, Martin O'Malley, practiced Giuliani-style zero tolerance. Anybody was arrested on the street corners. So a lot of women that we worked with were arrested. Lower rates recently in this CARE study, which was during COVID, because police actually stopped arresting people for sex work and drug offenses because the state's attorney didn't prosecute them, but still high rates and significantly higher rates of overdose. Trauma, unbelievable trauma that really have followed the life course of the women with whom we've worked. We actually did one of the few papers that have looked at PTSD among women who exchange sex, women who use drugs, and it's, of course, trauma is just written all over as a woman who's involved in drug user activism and organizing. Said to me once, like, trauma was my gateway drug. It's so funny that people focus on marijuana. Just look at people's lives and you'll see why they started drugs. She was a Smith undergrad, was assaulted, and then there was heroin, started using it. And while that's one story, it kind of always stuck with me. And she wasn't your garden variety drug user, as people would think. But she was in many ways, because the rates of childhood and current trauma and the work that we've done looking at the role of the police on the risk environment of women, incredible high rates of PTSD, higher than people who, samples of people who've come back from war, where a lot of the trauma work was conducted, because that was one long discrete event, and a lot of this is kind of multiple events over time. Okay. So what are policies and practices? So I'm gonna really quickly, harm reduction. Now I'm gonna talk about overdose prevention sites and a drop-in center that I started. You can see this quote from the National Harm Reduction Coalition. Full disclosure, I'm chair of the board. I mean, it's a great organization, and chair of the board for only a little while longer. I've been on the board for a really long time. So harm reduction is really interesting because it's practical strategies, it's a social justice movement, and it's a set of ideas. And it basically takes the spotlight off of focusing on problematic people who use drugs to problematic laws, taking the light out. Problematic laws, problematic situations. Why are there food deserts? Why is there concentrated policing? What are environments in which people are living and playing and working, et cetera? So one of the biggest, so it focuses on harmful environments, and it also hopefully centers people who use drugs in their experiences and creating solutions. You know, that saying, not about us. Oh my God.
Nothing about us without us.
Even with a cold, you remember that. Yeah, nothing about us without us. Her memory is ridiculous. Okay, so we have tools in harm reduction, and then services. These are kind of key parts of harm reduction programs. What are the tools that we have? What are the services that these tools are provided in? And then where should services be provided? Safe smoking kits. Does anyone know how that became popular in the media in the last, or legally in the last few years? Crack pipes. We still couldn't get over the racist notion of, like, crack is worse than all this other stuff happening. Marco Rubio caught wind in SAMHSA's call for harm reduction programs that drug supplies were going to be funded, including crack pipes. You can't pay for syringes still for the federal government. And then all of a sudden, all of these tropes around the crack epidemic, et cetera, and that the Biden administration was paying for people to smoke crack, and images came back from the 80s. So guess what happened really quickly? Such effective political strategy. Do you think the federal government will buy crack pipes anymore? No. So it's really important when people can get funding from other sources, because people smoke all sorts of things to give out pipes, which are not paid for by the government. They're like the new syringes. So I'm going to focus a little bit about the importance of where people are. A lot of harm reduction programs are in communities are integrated into other services that the best harm reduction programs are integrated into services that are already serving people who use drugs. Overdose prevention centers, those are places where people can consume drugs that they've previously purchased. There are only 2 legal sites in the US. There are a couple hundred sites around the world. They've been a part of public health policy. The most evidence comes from Vancouver, where the existence of a safe injection facility, so injection only at the time, went all the way up to the Supreme Court. So there was a lot of incredible offensive and defensive research, hundreds of articles about, it's called Insight in Vancouver. But other places, Australia also a body of research, but in many places in Europe, it's just been a matter of course, so they haven't had to write all these research. It's a part of public health reports. There's been a lot of work in the US to promote overdose prevention sites. We're hoping one's starting in Baltimore. There was an underground one in an unnamed city, which has stopped and hopefully is starting again. And just to say, the millions of times that people have injected, no one has ever had a fatal overdose. The only death I know of was a heart attack in an overdose prevention site in Germany. So this will be the norm at some point. It's really crazy that, you know, if you think about the place in New York or in Vancouver, I've been to all 3. Where is a place that people can do yoga, have acupuncture, see a primary care physician, get a great vegan meal, sit in a room and chill out? Single gender, trans room, coupling room. Is that not like treatment, buprenorphine available? I mean, shouldn't that be like on every corner where they're concentrated? I mean, that's an overdose prevention center. That, except for that one tiny room with hopefully ventilation so people can smoke, that becomes such a hot potato. But if you think about it, you know, you really are providing full services and at the point of the highest risk. Just makes sense that people are inside, not being arrested, not using a loan, oxygen's available, naloxone's available, et cetera. Okay, moving along to another place. And I know I'm gonna talk for a few more minutes. This is a center that I actually started in doing all of these observational studies, and there wasn't any kind of drop-in center. And if anyone wants to ask me about the hubris of a Hopkins researcher starting a drop-in center for people engaged and women engaged in kind of the street economy, I'm happy for you to ask that. But this was started just like the Check It van as the intervention of a NIDA grant looking at, if you saw all of the vulnerabilities, the structural determinants of negative health outcomes, whether it be STIs, or STIs besides HIV and overdose, we wanted to do something and start a place where people had access to resources. There weren't low barrier. These are all the services that are at the actual drop-in center. That's the building. We got money from the city to paint the building, that lovely lavender color. And so we started November 2017. Luckily, had been doing research for a while, and had a lot of, you know, friends in great places. So the health department provided, I mean, I think from the grant we had money for 1.5 people. It was really ridiculous. When the project director came in, she was like, what, are you joking? There's like no money for this place. But we borrowed reproductive health from the health department, 2 legal organizations, University of Maryland Legal Aid, that are still providing legal services. Farmers Market donates food to us. Lots of people donate clothes to us. We have an open closet. People can come in once a month. You see all the programs. So people before COVID could go in, watch TV. Their kids could play with games. Occasionally we watch kids when they were having services, but we didn't have babysitting services, daycare per se. They could get HCV testing, be treated for HCV, syphilis, get connected to PrEP care. We had a PrEP clinic with a nurse we eventually hired. That was through an R34. The other big grant was an R01. And then we had grew to have a lot of different community engagement programs that people asked for. Art classes, yoga classes, twerking classes, a book club. And then of course things really changed with COVID. We had to shut down. In 2018, we had started outreach services. That's our great outreach van with a free decal. The place that retrofitted this happened to fit, and that's like the Baltimore city skyline. So we love that, our church van. And the outreach was at night, provide all of these services. And over COVID, we started providing so many more supplies, and we closed down the center and we started a drop-off program. And during the drop-off program, so everything in Hopkins shut down in March of 2020, and we started going back out in a mobile van in a month later in April. And you can see that this just shows encounters for the 2020, 21, 22, 23. It shows Spark encounters over time, and they just escalated. They're about at 1,100 a month, serving 300 people. We've opened the drop-in center again. It's more of a drop-by center. We've lost staff. We have 4 new staff. We have a new director. I mean, COVID we go through hundreds of thousands of syringes, naloxone, food, clothes, granola bar, water, Plan B, et cetera. Basically, Spark is really a warehouse because people had called us, we had a Google number, and over time with COVID, it was great. We could reach out to people, text them, and they could give us orders. So we literally dropped by bags, and Spark you can see how many syringes and naloxone, for example, we give out over time. It's just a tremendous amount of supplies. We really kind of need our own warehouse. Slowly opening up the center, but a lot of what we do literally is meeting people where they are. We have great newsletters, also great, that we hand out every month. We have different newsletters and give advisories for different services. Always talk about bad date reports because the grant actually was focused on street-based sex workers. Anybody female presenting can go to Spark. Okay, implications. It is still this clicking time bomb. I really appreciated the opportunity. This was a new lecture for me to kind of go down this path. Obviously, I've talked about some of my studies and looked at some of the national data, but it is really astounding. And I hate to say that, I don't even think we've seen the worst of it. And I really learned through HIV and kind of felt it in my bones that I just really saw how health disparities, especially when I did work with incarcerated women in Raleigh, North Carolina, just follow the fault lines of society. And the bigger fault lines you have, the more entrenched something like an opioid epidemic is going to sit in a lot of communities, but really sit in certain communities and hard to change. My research is around harm reduction, whether it's evidence-based research, evidence-based programs and policies. And sadly, you still, up until recently, couldn't use harm reduction on the cover page of your grant. I mean, it's really incredible to think that this reducing harm, thinking about how to improve people's health, became so political. And that, of course, had very real repercussions. So there are a lot of people to thank. These are 2 very dear people to me that were lost in the opioid epidemic. Emmy was actually a study participant and came to work with us. She was one of the first employees of the Spark Center and sadly died alone of a fentanyl overdose. She worked with us for 6 months. She was an amazing mother of 3. And Will Miller was like this regal. If you look up in the New York Times, an article about Baltimore and overdose, there's a picture of him. He looks like a king. He was just this regal, incredible man who had an amazing heroin addiction for a really long time, helped do a lot of community organizing and started community organizing in Baltimore around the opioid epidemic, and also sadly died during COVID from an overdose. So that's all I have to say.
All right, let's take questions from the room. I know there are also folks online. Allie, are you online so you can see the chat? So let's start with folks in the room.
I can just speak.
Oh, it's for people on Zoom so they can hear you, if that's okay.
Yeah, of course.
Thank you so much.
Hi, great presentation. I'm Caitlin Tybal. I'm a third-year PhD in environmental health sciences.
Oh, great.
So this is a little bit outside of my typical comfort zone, but I also work with health disparity populations and was really fascinated by the content you talked about today. I have 2 quick questions. One being, so in recent years, I feel like there has been a big push for training and purchase of over-the-counter naloxone for bystanders. So I was wondering if you could just comment if you've seen a big impact of that push
How so impact? More
on
use
overdose. Yeah, on overdoses.
Yeah.
And then second, I'm curious so there were many different resources you talked about that would, if available, would help improve for example, like your study participants' lives. Have they voiced a particular preference for one? Like, if they could only choose one, would they pick syringes? Would they pick a center? That sort of thing, knowing that their drugs were clean. That's just a personal curiosity. Thank
I'm
you.
going to start with a personal curiosity. Thanks.
Okay.
And thanks for coming. By the way, there's really interesting environmental work with climate change, poppy growth, et cetera. So, I mean, impacts, I don't know how many people are in that field, but it is where our fields collide. When you go to a restaurant, do you only want the shrimp or I don't know why I'm bringing up shrimp and a hamburger or whatever. Like, I don't know where that came from. But do you only want one thing? I mean, do you only want the main course and not a drink? Or I don't know, whatever the metaphor in your mind is. Like, syringe, all these things should be together. People aren't going to, what do they prioritize? Like, of course they want to know about the drug supply. And if they're people that inject, they want, sterile syringes. All of these things are great if it can be at a drop-in center. A lot of times they're not resources for a drop-in center. I mean, it's ridiculous. And now, thank God, my endowed professorship pays for the rent. When we have a lull, Spark actually has its own around $900,000 worth of funding from SOAR grants, federal opioid grants that go through the state, and also Ryan White. But, so it's great we have a van, but we want that center open. And I'm really lucky that I can help pay when we have dips in general funds to pay for rent. All to say, it is not one size fits all. And I personally think people don't have to choose. If you can give them a granola bar, water, and a syringe, which is not that much expensive, people appreciate all of that. That's what I would say. I have no idea why I told you that I pay for the rent.
Others in the room? Holly, anybody online?
I have a question.
Okay. Go ahead.
Go ahead.
Hello, my name is Sarana. I'm also in the environmental program, 5th-year PhD candidate. I'm very interested in this intersection of, family, community health, maternal child health, and substance use. And when you talk about a lot of the structural barriers, especially like this campaign against even Black men and they're part of the family. I'm curious, how has the study participants in the population that you serve, how have they been responding to collaboration with police force and Blacks that are doing the work in good faith to protect these communities? However, there's still a lot of problems with policing and breaking up the family in this minute of fear. And it seems still that the people have to pick, kind of what Kate was mentioning, they're going to stay away from police, stay away from anything that could potentially do more harm. So I'm curious, what has been the sentiment as far as these collaborations, especially talking about those across disciplines that are working in good faith to improve the health outcomes of the community and families?
What collaborate? So I'm sorry. Tell me what collaborations you're specifically talking about.
So you had mentioned that the labs that are doing drug testing,
Yeah.
and
Gotcha.
working with police and police.
That's what I thought you meant. Right.
Hard to tell who are the good cops.
Right. So the study that we did with police, which was looking at the role of the police on the risk environment of street-based sex workers. And so we wanted to understand the culture of cops, 10-month ethnography with them. And then we had one of the first cohorts it was the first in 10 years of street-based sex workers, and one of the most rigorous studies. And it's ridiculous that because there's no surveillance just on sex workers, they are invisible. in the National HIV Behavioral Surveillance, for example. Now they're starting to ask questions about sex work in the last few years, more than the one that they had. So the whole point of that research was actually to look at the footprint of the police on the lives of women who were exposed to them on the streets. Our work was on the backs of a really interesting Human Rights Watch report, Open Society Institute report that exposed condoms being used as evidence, literally prosecutors using evidence. If women had 3 or more condoms in the state of New York or California, they could be arrested for, if they were found on the street, for sex work, which is horrific. And prosecution stopped because of a lot of advocacy, but there hadn't been longitudinal research on this issue. So that's why we did the Sapphire study. So everyone knew, it was a really crazy time, which is a whole nother thing, but it was right after Freddie Gray that our MOU went into effect. There was only one cop in a car. So we had researchers going out with police during the time of Freddie Gray, where they talked about a lot of stuff, and we all had a lot of feelings about what happened, and we were doing this research. We also collected the most data anyone's ever asked on extrajudicial interactions with the police, and also legally sanctioned. So, 20 questions, 2 scales about getting a warrant check, being searched, getting stuff thrown out of your bag, to sexual harassment, verbal harassment, sexual abuse, transacted sex for money with cops. So people in that study were traumatized by police. We always have amazing resource manuals in every area of town. We're very mindful of the mental health of our staff as well as study participants. People knew that we were working with police, or that study was about cops, because we asked so many questions about it. So that's the context of how we worked with police. And we presented some of the evidence back. In terms of working with crime labs, we're always open about the fact that we've worked with crime labs there, and a local Hopkins chemistry lab. They're the ones that have the drugs to be able to test. The state lab that we work with is not a crime lab. And people have more of an issue when they're taking your drugs. I mean, we're about to have a van where you bring drugs on the van, and people, although they're protected, because they're a research participant, and we're letting the police know. Have somebody who's is doing his dissertation on cops and police violence. He's getting in contact with all the districts and letting them know that we're there. They're not allowed to arrest people, but, people have to build trust. So that's a lot of an answer, because it's something that I think really seriously about. We've produced a lot of evidence about that have informed policy changes, and you can't avoid interacting with them when we do the kind of studies that we do. And a lot of them support harm reduction. A lot of them support overdose prevention sites. They would like this to be out of the streets. They're not social workers. That doesn't mean there's a lot of egregious behavior that we've documented, but, and my work is not around advocacy with cops, but I also know how they impact the people that we work with. Does that answer your question? I didn't answer about the families, but hopefully that was.
No, as we were talking about, you kind of touched on it though, like the trauma of adults circles down to families. So you did still touch on that and acknowledging that. And yes, thank you for your answer. Following up, how are police build trust? So this is very knowing that they want to help improve the community. So how are they building trust with this community that has been traumatized by their presence?
I mean, this is not my area. BEST is a model that's used in Baltimore. I mean, there's a lot of people that don't trust, and there's really no going back. These communities have just been, everyone knows someone who's been arrested and jailed. It's totally disrupted families. Cops are bad. It takes one asshole, and then that's it. It doesn't matter if you have a good police chief. Baltimore has a horrible history around police abuse. That's why they're operating under a consent decree. So I can't really speak to. I can tell you, I mean, that's what my foundation of knowledge of police with these populations. I know that in the drop-in center where people do, where there are lots of people who engage in illegal behaviors. We've never had cops come in. They've looked for a warrant twice in the 6 years we've been open. We really try to provide a safe space, bolster people with feeling good about themselves and knowing that they have a resource and hotlines to call, whatever, and from a lot of abuses, including their exposure to the cops. And you're welcome to get in touch with me if you have more questions. Yeah.
I just have a quick question about when an addict learns that what the content of their drug is, right? So whether it's safe or the percentage of fentanyl, do they still use it? What is the...
I mean, sure, people use it just like, I mean, I smoked for a really long time. I always hated the people that could like bum one cigarette, you know, when they went out for a drink. I was addicted to cigarettes. I knew the chemicals. I read the studies. You could have tested, and I could tell. I worked in Thailand. Those cigarettes were different than the cigarettes in the U.S., different chemicals. I still smoked them. So because I was addicted, because my neurons were screaming, you know, I had to like, where is the lounge in Tokyo? Where is the lounge in Singapore? But, you know, to quickly, I mean, I planned my travels sometimes. This was a long time ago. But we all have our things that we have in our life that we don't always use judgment. We don't expect anyone to change behavior. Sometimes people do. A lot of times people bring things in. I mean, we haven't done recent studies. The early studies we did ask and we published, would you change your behavior? There, of course, people, probably more people said they would than not. But harm reduction is reducing the harm that people experience when they're actually using drugs or not using drugs. So if they took, you know, snorted something, it felt weird, they bring the baggie in, or they bring the drug in, maybe they're going to make sure they don't use alone, or they're going to, you know, make sure that they have extra doses of naloxone. That, our business is that for people that use, and having the resources if they want to stop or, and yeah.
All right, is there one more online, or are we good?
Yes, Usha has a question.
Okay, one more, and then.
Okay, Usha, you can go.
Hi, apologies for not being there. Thanks for a fantastic presentation. I put it in the chat. I guess my question, when we talked about harm reduction, really means addressing harmful environments, and was interested in one, you know, what is the age range of people who came to your, you know, who used the walk-in facility? And, you know, the role of schools. I think those of us who've had teenagers or children constant things, these things are around the street corner, whether you're talking about expensive private schools or young, you know, public schools in a poor neighborhood.
I'm not quite sure the school piece. Our center is located, well, I'll say that people are theoretically above 18 when we don't ask people's age. Most people, and this is another thing, every study, the average age is the ripe old age of like 38, 42. So people who are willing to be paid, it's not that other people aren't, you know, younger people aren't out there, they're just not interested in maybe telling all their business, or they think they're more invincible, unless you're doing a study specifically with youth, which I've done, harder to recruit. So people who want to come in and hang out sometimes, like for the center, you don't have to have ever used drugs. You don't have to have ever sold sex. But so people come in and out. It's usually older folks who have time to hang out. Older meaning that age range, which is younger than mine. In terms of, and Spark is located in an area that has a high concentration of drug use. We look at arrest data. We had it before. There was a break. We have it again. We map 911 calls, and we look at overdose data to figure out where we go and recruit people. And also, we knew that there were dearth of services in this part of Baltimore and another part nearby, separated by the water. We don't do outreach to schools. I'm sure in my kids' fancy private schools, there are plenty of drugs. They're in 4th and 6th grade, so hopefully not yet. But those aren't the kids that we study. And those aren't the areas that we study. Much more hidden, much lower rates. They don't buy their drugs up there. They go downtown to where we're located. I mean, hypothetically.
Well, thank you very much. We've hit our time, and people have classes and other things.
Thanks.
So thanks for this. I think the message of harm reduction applied in the work that you do really resonates in the work that many people in the school do. So thanks for your time to do this.
Thanks.